Good evening, dear delegates and whoever present here. So today we are having a very, newer protocol in ovarian stimulation (CME). So I would like to thank Dr. Deepak Goenka and IHR for organizing this webinar, and Alembic for supporting us in this. And I would like to thank Dr. Deepak Goenka for making me a part of this CME of this webinar. So we have with us our co-moderator, co-chairperson, Dr. Ritika Gupta. So Dr. Ritika Gupta, she is at present working as senior IVF consultant and gynecologist in Nova IVF Clinic, Aligarh. So welcome, Dr. Ritika.
Thank you, ma'am.
And Deepak sir, you are here now?
Yes, Kanchan, I am here.
Yeah, so everyone knows Dr. Deepak Goenka. He needs no introduction. He's the director of Institute of Human Reproduction. So we welcome you, Deepak sir, here, and thank you for organizing this webinar. So we would like to start this webinar without much delay. We have with us our speaker, Dr. Preeti. So Dr. Preeti Pawar is at present doing fellowship with us in IHR. Yeah, she's an ex-senior resident of Lady Hardinge Medical College, New Delhi, and ex-assistant for professor of GMC in Hamidia Hospital, Bhopal. She's also an ex-consultant OBNG at Madhuban Hospital, Bhopal. And at present, she's doing a fellowship with us at IHR. So I would like to welcome Dr. Preeti Pawar. So today she'll be talking about the novel stimulation protocol in PPOS. So Dr. Preeti.
Good evening.
Hello,
Dr. Preeti,
am I audible? Unmute yourself.
Unmute. Yes, ma'am, I unmuted.
Good evening, everyone. With us, Dr. Preeti Pawar. She'll be speaking on next gen stimulation spotlight on PPOS. So over to you, Dr. Preeti.
So myself, Dr. Preeti, a fellow in IHR. Today my topic is next generation stimulation, a spotlight on PPOS. Just a minute. So first of all, we have to just refresh our knowledge about the controlled ovarian stimulation. Our aim in the controlled ovarian stimulation is to increase the number of egg developing in a cycle. So it includes of stimulation phase for follicular development and trigger phase for follicular maturation and separation phase for prevention of premature LH surge. So objective of today's topics are why there is need for pituitary separation in ART cycle, various drugs used in pituitary separation, and why the progesterone is for pituitary separation. So various clinical studies and future role of progesterone in controlled ovarian stimulation. So this is a normal HPO axis. GnRH is a pulsatile hormone which secreted from the HPO axis and acts on the pituitary gland and responsible for the secretion of gonadotropin, LH and FSH. This LH stimulates the theca cell to produce androgens, which is then converted to estrogen. Upon achieving a critical level of estradiol, it begins to have a positive feedback on LH release, which results in LH surge that initiate ovulation. So this is the normal HPO axis. This is the diagram showing a follicular recruitment in the menstrual cycle. So this is the LH hormone, which is responsible for final maturation of dominant follicle and rupture of the follicle. That is called ovulation. So the concept behind this pituitary separation in controlled ovarian stimulation cycle is to prevent this endogenous LH surge so that the ovulation not occur before ovum pickup. So the premature LH surge in the way is a major cause for cycle cancellations during the controlled ovarian stimulation in women undergoing IVF without intervention. This is shown by various studies. Thus, the premature LH surge should primarily be prevented. For that, following protocols are available: GnRH agonist, GnRH antagonist, and PPOS protocol. So this is the GnRH agonist protocol, in which in the starting phase flare up LH hormone increases, that is called flare up effect, and then the pituitary down regulations occur. And in the GnRH antagonist protocol, there is a direct gonadotropin suppressions occur. So over the past few years, the researcher focused on the replacement of GnRH analog by progestin for controlling the premature LH surge. So why the researchers focus on the replacement of GnRH analog? The downregulation of the GnRH agonist promotes the antral follicular synchronization, with the consequences being being increased procedure complexity, higher cost, and greater risk of OHSS by HCG trigger. While the GnRH antagonist produces rapid and reversible LH suppression with no initial flare effect. A varied proportion, 0.34 to 38% of the patient experiences premature LH surge, especially in the older and poor ovarian reserve patient. So in overall, the GnRH analog protocol needs daily subcutaneous injection and of higher cost. Therefore, there is an unmet need for a new method with improved efficacy, safety profile, and user convenience. So PPOS, a next wind of controlled ovarian stimulation. So how the progesterone works for the pituitary suppression? Progesterone is a key signal in the mid-cycle dynamics. A critical factor is there which controls the progesterone effect upon the pre-ovulatory secretion. Whether it is stimulating or inhibitory, or its timing of administration is not fully understood. The endogenous progesterone, which could hinder the rise of LH, as no spontaneous LH surge occurred during the controlled ovarian stimulation in luteal phase shown in the few studies. So this is the concept how the progesterone works for the ovarian suppression. So the effect of exogenous progesterone. So in the normal menstrual cycle, in the early mid-follicular phase, GnRH pulse increases and the number of progesterone receptor increases. That leads to the decrease in FHS hormone and LH accumulation. And in the late follicular phase, the increase in the GnRH pulse frequency and there is increase in the progesterone receptor activation. That leads to the LH surge. But when we give a high exogenous progesterone, that causes decrease in the GnRH pulse frequency, that leads to the decrease in LH and FSH secretion and stabilizes the GnRH pulse. Because of that, the LH surge will not happen. So the effect of exogenous progesterone reduces the GnRH pulsatility from the hypothalamus, thus inhibits the LH release associated with the increased estradiol level. Therefore, the new strategy for the controlled ovarian stimulation, that means PPOS, was gradually investigated. So there are protocols of the PPOS, the fixed dose PPOS protocol and the flexible dose PPOS protocol. In the fixed dose, we started the progesterone from the day two of the menses and the same day of stimulation till the day of trigger. And in the flexible dose protocol, when we monitor the patient with the TVS and when the follicle size becomes more than 40 mm, then we start the flexible dose PPOS protocol. So various types of the progesterone which are used in the PPOS protocols, this is the list. But the medroxyprogesterone and dydrogesterone and micronized progesterone, they are studied in the various literatures. So many questions comes in our mind that which protocol is good, PPOS or GnRH agonist? Is the PPOS is good, better than the GnRH antagonist? Which progesterone, medroxyprogesterone, dydrogesterone, or micronized progesterone is good? And the dose and duration, which is good? And in the term of outcome, dose duration of gonadotropin required, are more in which protocol and less in which protocol, and PPOS effectively suppresses the LH or not, the oocyte retrieval, fertilization rate, and pregnancy outcome is good in which protocol, and the risk of OHSS is less in which protocol, and which protocol is good for the different age profile and different patients like PCOS and poor ovarian reserve patient and normal responder. So there are so many literatures available which gives the answer of so many questions comes in our mind. So the efficacy of the progesterone in the PPOS. The progesterone have been shown in many studies to prevent the premature ovulation as efficiently as GnRH analog. Since 2015, the various studies have been done comparing the novel PPOS and GnRH analogs. Sorry. The efficacy of the different progesterone and varied dose and duration of the same progesterone and the outcome compared between these two groups. So PPOS versus GnRH antagonist, which is good. The PPOS is effective oral alternative for prevention of premature LSH, improve the good quality follicles and embryo rate, and improve the pregnancy rate. So various studies are available which shows these outcomes. So first study was regarding the PPOS was done in 2015 by Kuwang, as the medroxyprogesterone acetate is an effective oral alternative for preventing premature luteinizing hormone surge in the women undergoing controlled ovarian hyperstimulation for IVF. So this is the prospective controlled study, tertiary care academic medical center, and involved 300 patients. Concluded that the result shows that the medroxyprogesterone is an effective oral alternative for prevention of LH surge in women undergoing controlled ovarian stimulation. Finding will help establish a new regimen for ovarian stimulation in combination with embryo cryopreservation. So this is the meta-analysis of randomized control trial done by Sean Guan in 2021. As the progestin primed ovarian stimulation protocol for the patient in assisted reproductive technology. So conclusion of this study is the findings suggested that PPOS is an effective ovarian stimulation protocol and beneficial for the patient with different ovarian reserve function, means in hypo and hyper and normal responsive patients, which needs to be validated in more RCTs. So this is the one more study done in 2021, a meta-analysis of efficacy of progestin primed ovarian stimulation with medroxyprogesterone acetate in ovulation induction in poor ovarian reserve responders. So conclusion, poor ovarian responder can reduce, so PPOS can reduces the need for cycle cancellation, improve the follicle and embryos, and improve the pregnancy rate. Thus can present an effective choice for IVF CT in patients with the poor ovarian response. So this is the study, progestin for the pituitary suppression during ovarian stimulation for ART, a comprehensive systemic review including meta-analysis. It is done by Baris et al. In 2021. So the outcome of this studies are here. Overall, the duration of stimulation, gonadotropin consumption, and oocyte yield were similar with progestin and GnRH. Overall, live birth, ongoing clinical pregnancy rate per ET were similar, and the euploidy status of embryo from progestin for PPOS protocol was similar in conventional stimulated cycle. And regarding OHSS, although the pooled analysis suggests a significant lower rate of OHSS with progestin, the study comparing medroxyprogesterone, dydrogesterone, and micronized progesterone suggested similar ovarian response and pregnancy outcome. So wider implications are progestin can present as an effective option for women who do not completed a fresh ET, example fertility preservation, anticipated hyper responder, pre-implantation genetic testing, oocyte donor, and double stimulation cycle, means in the cycle which involve the stimulation follicular and luteal phase both. So the PPOS versus gonadotropin releasing hormone antagonist for PGTA cycle. Comparison between these two shows that similar euploidy rate in PGTA cycle. So many articles are available. Yeah, Young et al. In 2022 shows that similar euploidy rate across the different age group between PPOS and GnRH antagonist group. And the Pai et al. In 23 reported a lower euploidy rate in PPOS group. This is the only study which shows lower euploidy rate with PPOS group. But the rest of the study shows higher. Rest of the study shows similar or even higher rate of euploidy in the PPOS group. So Guile in 2023 also shows similar rate, and ATA-B into 2024 shows need for frozen embryo during the genetic testing. PPOS seems to be patient-friendly and cost-effective option for those undergoing pre-implantation genetic testing. And the recent study done by Van L in 2024 shows that higher euploidy rate and lower mosaic rate in the PPOS group. So this is the one recent study in 2025 by Lu Wong shows that both the PPOS and antagonist protocols have similar euploidy rate in PGTA cycle. So the euploidy rate in the pregnancy outcome in the pre-implantation genetic testing for aneuploidy cycle using PPOS versus GnRH antagonist protocol. So this is the study done in 2025 concluded that PPOS protocol did not negatively impact the euploidy blastocyst formation pregnancy outcome compared to the GnRH antagonist. The protocol indicated that the medroxyprogesterone acetate was an alternative option to the antagonist for the women undergoing PGTA. So this is the retrospective cohort study from the study analyzes the data from 598 PGTA cycles conducted between January 2017 till the October 2022, and the biopsies trophoectoderm from 2,218 blastocysts was collected for euploidy analysis. The inclusion criteria in this study are at least one of the following should be there: the advanced maternal age, recurrent miscarriages, and repeated implantation failure. So this is the group which is very concerned in the IVF cycle. So exclusion criteria includes maternal and paternal monogenic diseases, cancellation of the blastocyst culture due to no fertilized embryo or other reason, and recipient of the oocyte donor are excluded. So the key message of this study is the blastocyst formation in genetic study were similar, and PPOS demonstrated comparable pregnancy outcome, that means similar pregnancy outcome, and PPOS is responsible for the lower miscarriage rate. So this is the benefit of the PPOS. So which protocol is good for various patients like so this should be PCOS and poor ovarian reserve patient and normal responder patients. So the PPOS protocol seems to be improve IVF ICSI outcome for the women with a decreased ovarian reserve. And the live birth rate in the PPOS and antagonist protocol were comparable in the PCOS group. So this is the outcome of various studies showing here. This is the systemic review and meta-analysis done by Guwahati in 2023. The clinical value of PPOS for the women with diminished ovarian reserve undergoing IVF ICSI. So 14 studies with 4,182 participants were included. Publications year from 2016 to 2023. And the trial group treated with the PPOS. Controlled group treated with the CC and clomiphene citrate and letrozole. Concluded that the PPOS protocol seems to be improve IVF-ICSI outcome for the women with decreased ovarian reserve. This is the one more systemic review of literatures done in 2023 by Whiteshaw as the progestin primed ovarian stimulation outcome in IVF. So this study concluded that PPOS results in higher number of embryo formations, lower incidence of OAHSS, and equal duration of stimulation, number of retrieved oocytes, and number of M2 cycles are same. So moreover, it is beneficial in terms of easy administration and oral intake, so patient friendly, and in case of poor ovarian responder, and the patient with the PCOS and the woman with the advanced age and oocyte donor benefit more from the PPOS utilization than in the conventional protocol. So moreover, the selected study represents the PPOS as a safe technique as the prevalence of the congenital malformation was similar in those conceived spontaneously. So this is one more randomized control trial done by G. Quinn in 2024 shows that a live birth rate of the first FET following PPOS and antagonist protocol were comparable in the women with an anticipated high ovarian response. So in the high ovarian response, PPOS is similar. So the question, which progesterone is good, like dydrogesterone or medroxyprogesterone, which should be preferred. So in the term of LH suppression, oocyte retrieval, fertilization rate, and pregnancy outcome, these two drugs are same. And in the term of hormonal profile, dydrogesterone found as a weak pituitary suppressant, and it is more physiological and require less doses and duration of gonadotropins. So post-trigger, more FSH and less LH and same E2 and P2, and more specifically in the poor ovarian reserve patient. So this is the study, recent study, the 2025 by Moharam, comparing the dydrogesterone versus medroxyprogesterone as a PPOS in the patient with the IVF and ICSI. This is the systematic review. A total of 3 studies involving 1,172 patients were analyzed. Both the dydrogesterone and medroxyprogesterone found effective and safe for LH suppression in PPOS protocol, with dydrogesterone potentially offering a more physiological hormonal profile and reduces the gonadotropin use, with no significant difference in the oocyte yield, fertilization rate, and clinical pregnancy rate. So these following outcomes are similar. So these 3 studies are included in this systematic review. Jiang et al. In 2021, Huang et al. Studies in 2019, and one study is from 2018. So all the study shows no significant difference in the oocyte yield, embryo development, and pregnancy outcome in both the groups. And now here we compare the fixed and the flexible PPOS. Among the poor ovarian reserve patient, the flexible PPOS protocol provided more retrieved oocyte, higher clinical birth rate, and similar outcome in preventing the premature utilization. This is the outcome of various studies showing here that the study done in 2024 by Yoshi, comparing the fixed versus flexible PPOS protocol in the patient-oriented strategy encompassing individualized oocyte number, means Poseidon group 4, concluded that among the poor responder, The flexible PPOS protocol provided more retrieved oocyte than the fixed protocol, possibly because the total dose of the progestin was lower in flexible group and progestin were not administered at the time when ovarian stimulation was initiated. So in the initial phase, there is no progesterone, so that can be the responsible factor for better outcome. So this is one more study in 2023 comparing the flexible and conventional progestin protocols. The novel flexible PPOS protocol appeared to achieve the higher clinical birth rate even without significant difference and with the medroxyprogesterone consumption compared with the conventional PPOS protocol. Conventional means fixed PPOS protocol in low prognostic patient, means poor ovarian reserve patient, it is better. One more study in 2023 by Gilson shows that both fixed and flexible protocol had statistically similar outcome in preventing premature luteinization and other cycle parameter. And the flexible protocol seems to be effective as fixed protocol for the patient with diminished ovarian reserve. However, the further prospective study should be conducted to validate the research of our study. So this study shows similar outcome with these two protocols. So at the end, the conclusion of various studies shows that PPOS may be preferred over GnRH analog in oocyte donor cycle, fertility preservation, and PGT for aneuploidy and monogenic diseases, and patient at the risk of OHSS like PCOS, and the patient with poor ovarian reserve, and non-conventional protocols such as luteal phase stimulation and dual stimulation. So let uni of the PPOS protocol. When the IVF relied on the fresh ET, the progesterone could not be considered for use during control ovarian stimulation in follicular phase because it was known to have a negative impact on endometrial receptivity. But it is better in the PPOS protocol when we stimulated in the luteal phase. So in the FET cycles, it has become feasible to use the progestin as an alternative agent for suppression of premature LH surge during the controlled ovarian stimulation. So this is the SWOT analysis of PPOS. The strength of the PPOS is it is well tolerated, low cost, same number and quality of the oocyte we get, and same pregnancy rate, and there is no risk of OHSS. So, and the weakness is few RCTs are available. The PPOS we can use in the phase and FET cycles only, and the increases total dose of gonadotropin. So the opportunities are more euploid blastocysts in the poor responder in one cycle, duostim, and the patient-friendly fewer injections, easier scheduling, or random start. The random start protocol we can use in the PPOS. And the threat of this PPOS protocol is that change in the current practice need for a good cryopreservation in the FET cycles and obstetric and perinatal outcome have limited data. So further research are needed. However, we consider that more randomized clinical trial must be conducted to estimate the minimal effective progestin doses in PPOS to make it efficient, safe, and cost-effective, along with long-term consequences on the children using this regimen. Thank you.
Thank you, Dr. Preeti. It was an excellent talk. I think you have covered all the points and many studies you have shown, many articles also. So, Preeti, I would like to ask you, like, theoretically, I think you have shown many articles. What is your practical experience?
So,
How do you use what you are using practically? You go ahead with medroxyprogesterone or dydrogesterone, which one you prefer, and what are your results?
so ma'am, in our institute, we use dydrogesterone and as a fixed dose protocol from the one of the stimulation we started the dydrogesterone with a dose of 10 milligram BD till the ovum pickup, and we continued that for the withdrawal bleeding after ovum pickup.
Yes, we continue it because in the studies you have shown in some of the studies till the trigger, but if you continue, the patient will not have a withdrawal within mid of the cycle.
Yes.
Right. And in
Yes.
duostim also you can continue it, then the patient will not bleed in between.
Yes.
And yeah, is there any particular indication where you would like to use medroxyprogesterone instead of dydrogesterone?
So, so medroxyprogesterone causes uh,
Okay, like medroxyprogesterone is known to cause more profound
more
pituitary
profound effect.
suppression. It causes more profound pituitary suppression and it
Suppression.
suppresses the LH more than dydrogesterone. So in PCOS patient where the LH is actually more in the body, so in those cases it has been shown that if you are using medroxyprogesterone instead of dydrogesterone, you may get some better oocytes, the quality. So
Yes.
in those cases, you can go ahead with medroxyprogesterone also if you want to. But in rest of the cases and in patients with poor ovarian reserve and all, I think in those patients, the dydrogesterone is a preferred route. So Dr. Preeti, I have one more question. Like of late, you have shown one article also where the rate of aneuploidy is more in patients more than 38 years. But I think there are some more articles where we have seen that the this PPOS is causing more aneuploidy in elderly patient. Did you get any more articles on that, or that's the only article which you could find?
Ma'am, there's I found only one article that was a PI in 2023 that shows the decreased means more aneuploidy rates in the PPOS.
But I think there are some more recent articles which are showing that there is more aneuploidies in elderly patients if you are going ahead with PPOS.
PPOS. So,
Yeah.
ma'am, I didn't found that.
You didn't find it. Okay, fine. Yeah. So most of in our institute, we are using PPOS in all the group of patients. In some elderly patients, I do nowadays want to go ahead with the anti protocol only for the fear of aneuploidies in elderly patients. Otherwise, we are using PPOS for all our patients. So I would like to invite questions from all the other attendees also. If someone has any question, then we can go ahead with the questions.
Kanchan, I have one comment and few questions. I think last week another article was published in Fertility Sterility, I think 10 days back only, which was showing that with PPOS there is a more requirement of gonadotrophin doses in comparison to the antagonist cycle. And we are using at our institute PPOS since I think 3-4 years. Almost more than 90% cases we are using PPOS. Am I correct, Kanchan?
Yes, sir. Yeah, I think around 3 years. Yeah.
Yeah. And on and off, you have commented that our requirement for gonadotrophins has increased. I do
Yes, sir.
remember.
It has increased actually. The duration has also increased, the dose also increased. But
So
maybe
last,
so maybe the flexible protocol, if because we are using the fixed protocol where we are starting from day 2. If we go ahead with the flexible protocol, maybe we can decrease the doses of the gonadotropin as Preeti has shown in some of her articles.
yeah, I was never aware about the flexible protocol of the PPOS.
The only
This was something new for
concern,
me today.
yes, sir, and the only concern I have here is will it cause like if you are using an antagonist, it causes an immediate suppression. Will adding the progesterone once the follicle is 14 cause a immediate suppression of the LH? That is my concern here. So how much time it actually takes for the suppression of the LH? Dr. Preeti, can you just comment on this?
Yes, ma'am. I just go through the various studies, and the study shows that it is the similar effect of the flexible and fixed dose PPOS protocol for the LH suppression.
Yeah, that's true, Dr. Preeti. I wanted to know how much time it will take. Suppose we start the progesterone tablet now, how much time it will take for the LS suppression? As we say that if we are using antagonist, if when we give antagonist to a patient, within 4 hours the suppression is there. So is there any particular time with the which the patient will take before the LS suppression is there?
So that, madam, I don't know.
Okay, I think we will have to study more regarding that because
Yes.
we are also using the fixed protocol. So if the flexible is better in the poor ovarian reserve patients, and if it decreases the doses of the gonadotropins, then I think we can go ahead with the flexible protocol also.
Mm.
I think another thing we have to study about the flexible, okay, which one is the better progesterone? Should we use the stronger progesterone like medroxyprogesterone or we can go ahead with the milder progesterone, dydrogesterone?
So
Preeti, you
here,
did not.
I would like to comment that in if there is a more profound suppression in some of the patients when we are giving the trigger, there is the LH surge is not proper. In some group of patients, not all. So that was the reason why some of like first in the first place we shifted over to dydrogesterone instead of the medroxyprogesterone.
Yeah, I do remember that. Uh, I think Saurabh had a recently, I think last week we discussed, he had a patient which has a profound LS suppression. He was
Hmm.
using recombinant FSH. I think we discussed this patient.
Yes, sir, we did discuss this, yeah.
Preeti, did you tell
Yes.
anything about the dosage of the all the progesterone? I don't remember that you told anything about the dosage of the progesterone.
Yes, sir.
Right?
So one study is available which shows the doses of various progesterone. Can I show the slide?
Yeah, please, Sona.
So this is the study which shows the doses of the progesterone which is required for ovulation inhibition. So micronized progesterone dose is 300 milligram per day, and for the dydrogesterone, the dose is more than 30 milligram per day. And for the medroxyprogesterone, the dose is 10 milligram. And these are the other progesterones: sapropteron acetate 1 milligram, no-mestyl acetate 5 milligram, norethistron acetate is 0.5 milligram, and levonorgestrel 0.05. Drosperinon, this is the fourth generation progesterone, the dose is 2 milligram.
What is this transformation dose?
So this is the transformation dose responsible for the changes in the endometrium.
Okay.
So written here, sir, the progesterone effect is is the induction of characteristic changes in the estrogen primed endometrium. The effect is often expressed by the difference in the doses required for endometrial transformation. So this transformation dose is endometrial transformation dose. And the antigonadotropin effect of the progesterone is capacity to inhibit the ovulation. So this is the antigonadotropin dose, and this is the endometrial transformation dose.
Okay. And we are using dydrogesterone 10 milligram twice daily, not
Yes,
thrice
20
Yes.
daily.
milligram. Hmm.
Yes.
But 20 milligram, I think, is usually sufficient. We have never
Yeah,
seen
it's
like
working well.
it's
I,
working
I
well.
I don't recall any case where there was LS
Mm.
cells.
And medroxyprogesterone, if you use a 10 milligram, is enough.
Enough.
And,
Definitely
well,
enough.
mhm.
Preeti, go back to your test, slide number 12. One more back. One more. Next slide. Slowly. You are moving too fast. Next.
Sir.
Ritika, are you using progesterone PPOS? Next slide.
I haven't started using it, but some of my colleagues are using it and they are having a very wonderful effect. So that is why I actually asked for this webinar. So, one question actually I do have
Uh,
regarding this, ma'am, if we are using a higher dose of gonadotropin and maybe HMG or recombinant FSH like 300 international units per day. So which progesterone do you prefer? Will you still prefer the dydrogesterone or will you prefer the MPA?
Dr. Preeti?
Dr. Preeti?
Good evening, ma'am. Ma'am, we prefer the dydrogesterone only.
Okay. For even for 300 or maybe 375 of dosage daily, is it sufficient, the dydrogesterone being a milder progesterone, is it sufficient to prevent the LH surge?
Yes,
Ritika, I
ma'am.
think
Because
you're
yes, ma'am. Because this suppresses the endogenous LH and FSH, and we are giving exogenously that recombinant FSH. So I think the dydrogesterone will not affect the exogenous gonadotropins.
I think
Okay.
Ritika here, like whatever dose you are using, that does not affect your, because in like PCOS patient also where you have number of follicles developing, there also you are using the same dose. So the
Mhm.
dose is the same for the suppression, pituitary suppression. So that will not change with the amount of gonadotropins you are using or whether with the number of eggs, the number of follicles which are developing. So that doesn't change. The dose doesn't
So,
change.
so in PCOS patients, like you said, that we should be using, if I don't know whether I misunderstood it. In PCOS patient, you said that instead of dydrogesterone, ideally MPA should be used. So, ma'am, what is
There are
the reason?
Yeah, there are few studies which have shown that in PCOS patient, like in medroxyprogesterone, if you are using, because that causes a more profound suppression. So it
Okay.
suppresses the LH more than the dydrogesterone. So in PCOS patient, as the LH level is already high, the endogenous LH level. So if that is suppressed, it leads to a better egg quality.
Okay.
So I have actually have sometimes used medroxyprogesterone in PCOS patient, and I do get better eggs. I have used sometimes in my PCOS patient, and I'm getting better eggs. I think so.
And ma'am, in case we are using medroxyprogesterone, so which trigger do you prefer? Like you're saying that sometimes it causes over the head suppression of the LH.
Yeah.
So which trigger do you prefer? Whether you are going more for a dual trigger or you are going for an Ovitril if it is a very decreased risk of OHSS, or you're just sticking to the decapeptyl or the GnRH agonist trigger?
See, the principle for trigger is same whether I'm using an antagonist protocol or a PPOS protocol. Uh, Dual trigger only in patient who are poor responder. Never give a dual trigger in hyper responder where there is a risk of OHSS. There we always go for an agonist trigger. But if there are very few follicles developing, like in those cases, you can always go ahead with a dual trigger because that will increase the chances of getting more M2 oocytes, better quality also. So either I'm using an antagonist protocol or a PPS protocol, the principle for trigger is the same. So it's like that, yeah.
Thank you.
Pritika, agonist trigger works very well.
Okay, sir. So, I was
Mm.
actually asking for the one which are causing more suppression of the LH, like the MPA. If we are using MPA, so like you were discussing, when you are using it in some patient, it has caused profuse LH suppression and all. So, for that case, I was asking, so is it enough to use one, or do we need to? Does the trigger anyhow makes any difference?
No, no, Ritika, don't worry. Go ahead. It will
Okay,
work.
But
okay.
yeah, if there is number of follicles developing anyways, you should not use a dual trigger for the risk of
Huh.
OHS. It will
Risk
always
of
be there.
OHS is there.
Will always be there, yeah.
Okay,
So there is one
okay.
more question in the question box. Can we not use norethistron, Dr. Preeti? So Dr. Rohit has a question here. Can we not use norethistron?
So, so there are very less, matlab no, there are no study available regarding the
Yeah,
norethistron. So
yeah,
we,
that's true.
so
Yeah, we don't I don't think we have sufficient studies for norethistron, or any of us have either used norethistron. Either it is medroxyprogesterone or dydrogesterone.
Yes.
These two are the other progesterone which you showed also. I don't think anyone is using that.
Yeah, theoretically, yes, we can use definitely, but practically we don't have much studies about these things.
Now we have one more question, Dr. Preeti. Dr. Vandana wants to know what is the protocol used in IHR from day 2, 3 of menses up to trigger. Dr. Preeti.
Protocol is PPOS protocol we are using here. We start we used dydrogesterone in the dose of 10 milligram BD, started from the first day of the stimulation.
We start the gonadotropin the
Irrespective of
same day. The same day we start
same day,
the gonadotropin, and the same day we are starting the dydrogesterone also.
dydrogesterone,
So this is
irrespective of the day of menses.
irrespective of, we are using from
मतलब
day 1 day to as soon as the
day
patient
to
comes after menses, we start the gonadotropin. At the same time, we are starting the progesterone also.
progesterone. Okay.
Hmm.
Anybody in the group other than IHR is using PPOS? I can see Bandana is here. Suchitra is there. Dr. Astha is there. Preeti is there. And anyone else is using PPOS, please comment in the chat box. It will be interesting to know how many people are using PPOS.
So Bandana has answered that she is not using till now, but she's very much interested. So Bandana, you can very safely go ahead with this protocol because we have been using it since quite a long time, getting good results. And there is actually we have not got premature ovulation in any of the patient, I think.
No, we have not got, for sure.
For sure, we have not got, yeah. Suchitra is not using as of now. Suchitra, you can use it. It will decrease the number of injections your patient is getting. Okay, Dr. Preeti is using it till the day before OPO. So, Dr. Preeti, here we would like to know once the OPO is done, what do you do? Otherwise, the patient will start the then the body will be producing the endogenous progesterone will be there now from the corpus luteum. Maybe that is not leading to menses. I don't know. The Dr. Preeti will only comment. Dr. Preeti, please let us know.
Can we unmute Preeti?
Yes, ma'am. Sir, yes,
Preeti
sir.
Moon, not this Preeti, but another Preeti.
Preeti Moon, Dr. Preeti Moon.
सर बेसिकली जब हम लोगों ने स्टार्ट किया था तो ये था कि पता नहीं एलएच सप्रेशन कितना हो जाएगा, मतलब प्री मेच्योर कभी रप्चर नहीं हो जाए उसके हिसाब से, मतलब जस्ट आउट ऑफ फियर वैसा स्टार्ट किया था। तो फियर अभी तक कंटिन्यू है, उसी फियर के चलते हुए हम लोग बस टिल द डे ऑफ मतलब डे बिफोर ओपीयू तक यूज कर रहे हैं। बस यही था सर, और कुछ नहीं।
मैं विड्रॉल ब्लीडिंग होता उसके बाद?
हाँ, withdrawal bleeding.
Did you face any withdrawal bleeding in these cases?
No sir, no sir.
Kanchan, we too can stop this because you are making sense. It makes sense that
The
the
body
corpus
will
luteum
produce,
will form and it will secrete the endogenous progesterone.
बट इतना साइकिल कंट्रोल नहीं रहेगा शायद जितना हमारे इसमें रहता है.
Looks like, but we have to try.
We can try, yes, we can try in some of our patients.
When
Let
Preeti
us
is
try
telling
with the
कि उनको नहीं मिल
donor.
रहा है, तो definitely we also can try.
Yes, sir.
रिगार्डिंग द डोज ऑफ गोनाडोट्रोपिन ऑल्सो, मतलब हम लोगों को कोई ज्यादा नहीं लगा कि गोनाडोट्रोपिन हमारे ज्यादा कंज्यूम हो रहे हैं क्या, ऐसा कुछ फील नहीं हुआ। लाइक जैसा भी हम लोग डिस्कस कर रहे थे कि गोनाडोट्रोपिन्स का कंजम्पशन जो है वो थोड़ा ज्यादा हो रहा है, तो वैसा तो नहीं फील हुआ सर। बाकी लोगों का क्या एक्सपीरियंस है रिगार्डिंग द
मुझे
डोज
तो
ऑफ
हो रहा है,
गोनाडोट्रोपिन?
लाइक प्रीति, द डोज भी मुझे लगता है ज्यादा यूज होता है आजकल, और ड्यूरेशन भी। इंस्टेड इन हाउ यू आर यूजिंग प्रीति, फिक्स प्रोटोकॉल और द फ्लेक्सिबल वन?
Fixed, fixed only from the date
फिक्स
of
ओनली
the
ना?
from the day of the start of the stimulation only.
ओके, आई थिंक वी कैन रीड मोर अबाउट द फ्लेक्सिबल वन, उससे शायद डोज कम लगेगा पेशेंट्स को।
हाँ शायद, लेकिन वही वो
हम्म।
थोड़ा यूज करने में, मतलब ट्राई करने में थोड़ा हिच है। आई थिंक कर सकते हैं स्टार्ट। पुअर रिस्पॉन्डर्स में मुझे और ज्यादा डर लगता है कि उनमें
हम्म।
वैसे ही थोड़ा पीपॉस में, क्योंकि
मे बी,
फ्रेश का थोड़ा
या मे बी जैसे हम
चांस।
एंटाक में स्टार्ट करते हैं, एंटाक का जैसे अपना 2 है, फिक्स में डे 6 है, तो मे बी वी कैन मेक दिस आवर फिक्स प्रोटोकॉल की वी आर स्टार्टिंग फ्रॉम डे 6 बिफोर द फॉलिकल रिचेस 14 mm। वी
हाँ
कैन,
ये एक
हाँ,
ऑप्शन हो सकती है।
ये एक ऑप्शन हो सकती है, वही।
I think Bandana is asking something.
But otherwise, till what day do you continue progesterone in IHR? Okay, Vandana, we are after OP also we give progesterone for 10 days because we want to match the patient's menses with her previous date. So usually the stimulation will go around for say 11, 12 days, then the pickup, then 10 days of progesterone, and then she will have her menses. So it, somehow matches her LMP, and the patient is not having a short menstrual cycle. Even in donors, yes, even in donors, we are doing that. Have
Anybody
you
has noticed
compared the
premature
sandwich?
rupture in PPOS
So,
protocol?
sorry, Preeti, can you please repeat your question?
Anybody has noticed premature rupture of follicles in PPOS protocol?
No, we have been using it since quite a long time now, but we have not got a premature rupture of follicle. We have not got.
I have seen one patient जिसका
Okay.
हो गया था। आई हैड वन पेशेंट, मतलब अभी काफी पीपॉस ही ऑलमोस्ट 90% पेशेंट में पीपॉस प्रोटोकॉल ही जा रहा है, बट आई हैव नोटिस्ड ओनली इन वन पेशेंट। अब पेशेंट था तो मेडिसिन भी लिया ही होगा उसने, एक डोनर में हुआ था, लेकिन डोनर ने तो मेडिसिन मिस कर दिया था, तो उसका था, लेकिन एक सेल्फ में भी हुआ था रप्चर। तो
Any
ये जानना चाह रही
particular
थी कि बाकी लोगों ने कभी नोटिस किया कि
कोई
रप्चर हुआ
पर्टिकुलर
था?
प्रोफाइल पेशेंट का जो आपको स्ट्राइक किया हो कि इस पेशेंट का ये प्रोफाइल है, मतलब
फॉलिकुलर प्रोफाइल बेसिकली ये था कि जो डे टू डे थेरेपी था, इट वाज अ काइंड ऑफ पीसीओएस पेशेंट, बट द स्टिमुलेशन वाज नॉट लाइक, कि ऐसा नहीं था कि बहुत ज्यादा पीसीओएस के हिसाब से उसका रिस्पॉन्स थोड़ा कम था।
अच्छा, फॉलिकल्स
मतलब
कम बने थे।
हाँ फॉलिकल्स कम बने थे, तो पता नहीं शायद वो क्वालिटी का ही कुछ था कि, बट लेकिन वो सिर्फ एक उसी पेशेंट में मैंने रप्चर नोटिस किया, बाकी तो नहीं कभी रप्चर नोटिस
सेल्फ
किया।
होने से भी प्रीति, समटाइम्स द पेशेंट मे मिस द डोजेज, यू नेवर नो।
हाँ हो सकता है वो एक्सेप्ट ना करें, डोनर ने अपनी
हाँ,
मांगी होगी, उसने एक्सेप्ट नहीं किया होगा।
हाँ, they must have missed. Asha, we have one more question from Dr. Rohit, who is saying, have we compared the sandwich protocol with PPOS protocol for number of oocytes retrieved? Okay, so Dr. Preeti, would you like to answer this question, Dr. Preeti Pawar?
Yes, ma'am. So, ma'am, I have no idea about that, ma'am.
Okay.
And then I don't think she has experienced sandwich protocol. By
Yes.
the
Yeah,
time she joined us, we have abandoned more or less sandwich protocol.
Hmm.
uh, not abundant exactly. Sometimes I do use, but in a modified way. Like, and initially we used to give for 7 days, but nowadays sometimes if I feel like I have to give, then I give for 3 days.
Yeah.
And so somehow modified way I am still using. Yeah. So Dr. Rohit, this coming back to your question, have we compared the sandwich protocol with PPOS protocol for number of oocyte retrieved? So Dr. Rohit, I don't think in literature we have any such study which has compared the sandwich protocol as such with the PPOS protocol. But I think if you think about the physiology, it will be the same. Either if you even if you are using the sandwich protocol and you want to do the, because if you think why you are using the sandwich protocol, because you want to lengthen the follicular phase of the patient, isn't it? So if you want to do that with PPOS protocol, I think you can combine both. But as per I know, there is no comparative study between the sandwich protocol and the PPOS protocol. There is one more question from Vandana. Gonadotrophins, do you start with FSH for 5 days and LH FSH from day 6 like antagonist protocol, or how is it? Uh, uh, Dr. Preeti, would you like to answer this?
Ma'am, can you please repeat your
Yeah, do you
question?
start with FSH for 5 days and LH FSH from day 6 like antagonist protocol, or how is it? Means like basically she wants to ask you that what gonadotrophin you are using. Are you using Gonal-F or you are using HMG? With what gonadotrophin can you combine this PPS protocol? This is her question.
So this is not depends on the protocol. We use gonal-F in the patients where the LH baseline LH level is less than 2.
No.
We
Or
prefer
more than two.
Okay, Preeti, here I would like to
otherwise.
tell that the gonadotrophin, the choice of a gonadotrophin will not depend on the PPOS protocol. Any gonadotrophin you can use, Vandana. You can go ahead if you want to use the FSH, you can go ahead with the REC FSH also, or if you want to use HMG, you can use that also. So basically, the PPOS protocol we are using for the LH suppression. So whatever gonadotrophin you use, you can go ahead with that, whichever is your preference. So that will not affect your results. So we have a question here from Dr. Smita. She wants to know, after pickup in an IVF cycle, will the corpus luteum secrete adequate progesterone? Okay, now if we are not doing the fresh transfer, and also I think we are all don't have so much of practical experience. Maybe Dr. Deepak sir may be able to tell us how much progesterone, because after the pickup, if you are doing the fresh transfer also, we are using giving exogenous progesterone. But as I have seen other doctors who are using the fresh transfer, they are giving less progesterone than in an FET cycle, with the hope that the corpus luteum is also secreting the progesterone. But how much progesterone it secretes, that is, I will not be able to answer that. So, Deepak sir, will you kindly
Concern, I
answer the
think
question?
Dr. Smita is asking about the PPOS only. She is concerned whether progesterone secretions will be adequate
No,
or
sir,
not.
she wants to know whether we should stop the question. This is the question
I
related
think we can
to
unmute Dr. Smita also, and we can communicate with her. Can we unmute Dr. Smita Das? I am going to stop all my cases after pickup from tomorrow onwards.
Hello,
I
sir.
will. हाँ स्मिता आपने की what exactly
So
you are
my
looking at?
my question was actually since Preeti Mood told that she usually stops the PPOS before the pickup, then the genuine concern that you had that after pickup there will be immediate progesterone withdrawal sort of thing, because won't be sufficient progesterone, because after the all the cumulus ophorus will be taken out after pickup, from where will be the adequate progesterone come from?
No, that was the primary concern we all had. That's why we continued till 25th day or 10 days after the pickup. But
Yes, sir.
now studies, whatever Preeti Pawar, not Moon, Preeti Pawar is showing the studies. All the studies are stopping the PPOS at the time of trigger. And Preeti Moon also is saying they are also stopping. I am motivated to stop in all my patients from tomorrow onwards. I will give you a feedback. Maybe after 1 month,
Okay.
I will give you a feedback whether
Can
they
we
are
start
having
with the
withdrawal or not.
donors first?
Yes,
Deepak sir,
this is what I am
can
planning.
we start? Let us start with the donors. If in 2, 3 donors, if we use, we will come to know whether they are having menses or not.
Yes,
So,
yes, yes, yes. From tomorrow onwards only.
yes, sir. Acha, now there is one more query. What is the route to use micronized progesterone, vaginal or oral in PPOS? So, Dr. Preeti Pawar, would you like to answer this question?
So in which phase, during the stimulation phase or after the pickup?
No, the root, the micronized progesterone, as we all say that the micronized progesterone should be given vaginal, right? We
Yes.
don't want to
PPOS,
give
as
it
a
oral.
PPOS.
In
As a
PPOS,
PPOS, as a PPOS.
uh,
So
he wants
the
to
for
know
the
the route in PPOS.
so for the micronized progesterone, as we know, the vaginal route is good because it passes the first pass metabolism. So that is the only concept.
I
But
don't think.
Dr. Preeti, here again, I have one concern. How much sometimes in some patients we have seen that the absorption is not proper. Suppose the patient is having some vaginitis or something. In those cases, the absorption of the progesterone is affected. We do get patients where after giving so much of progesterone, also the blood level is not maintained. You
So
have seen
Yes,
in the practice.
yes, sir.
So
Yes, ma'am. But the vaginal progesterone increases the progesterone locally, like in the uterus, that we need.
but Preeti,
And
here we are not concerned about the local progesteronic effect. We are concerned about the LH
the
suppression.
LH surge, yes, sir.
So vaginal, will it be sufficient? I have not come across any studies.
So
hmm.
yes, sir. There are no studies available regarding this.
Logically speaking, it should be oral, not vaginal.
Hmm.
But oral again, so micronized, we know that the sustained release tablet, then I think we'll have to give because the capsule form, due to profound first pass metabolism, I don't know how much effective it will be.
Yeah, we don't have much
Rohit,
studies over the micronized progesterone and the as a PPOS.
Hmm.
what I feel, Dr. Rohit, first to be on the safe side, you can start with either dydrogesterone or medroxyprogesterone, and once you gain more confidence, then maybe you can try the micronized progesterone and give us a feedback too. We would like to try also.
Can we unmute Dr. Rohit Pradhan? Concern he is not our fellow. I don't. Dr. Rohit, can you introduce yourself? Where are you from? Can we unmute Dr. Rohit?
Yes, sir, I'm trying, sir.
हेलो
Yeah.
हेलो
हेलो, अरे रोहित तुम हो?
हाँ सर मैं ही हूँ
ये
सर
प्रधान कब से हो गए?
सर वो पहले से ही था बट आधार कार्ड पे नहीं था तो वो थोड़ा सा ये हो रहा था डबल सरनेम था सर एक्चुअली
अच्छा, मैं सर कोई हमारा कोई गेस्ट आया है रोहित प्रधान
नहीं
बोल के।
नहीं सर मैं ही हूँ सर
अच्छा सर, ये अपना रोहित है।
हाँ, अपना रोहित है।
यस मैम
Yes, Rohit. So, Rohit, have you started using this PPOS or till now you have
नहीं
not
मैम नहीं
started?
मैम अभी मैं फिलहाल तो लेवल 1 पे काम कर रहा हूँ सो अभी तक तो
Okay, okay.
पीपॉस नहीं स्टार्ट किया है तो बस ये चल रहा है अपना ओवुलेशन इंडक्शन विद टाइम इंटरकोर्स या कभी कभी आईयूआई कर लेता हूँ बस
अच्छा. Hmm. Okay, Dr. Vandana has again a query. She's still scared to use PPOS because in her fellowship day she has not used it. You're very right, Vandana. When we do something in our fellowship days, we feel more confident when we are using it ourselves or we see in our day-to-day practice using. But believe me, like we have been using it for I think 3-4 years now, no, Deepak sir, and we are getting
आराम से
result.
3 साल से
Yeah.
तो डेफिनेटली यूज कर रहे हैं।
Yeah, so so Vandana, I think you can confidently go ahead with this. And now we are starting, just this is not our topic of discussion, but just out of the way, I would like to, because we have many of our past fellow students and now consultants, of course, with us. So I would like to just share with you all that PPOS also, like now we are using oral antagonist also. I have used in some of my patients and we are using it for our donors. We have used the oral antagonist, and in the oral antagonist have also, responded very well. We are not getting any ovulation.
I think we have good number of data. Dr. Manoj and Dr. Kanchan is helping us to accumulate and filter the data. I think we should be there available. Our data should be available with oral antagonist within a month. What do you say, Manoj and Kanchan?
Yes, yes, sir. Manoj is also here, sir.
I know. मैंने देखा मनोज को।
So what is the dose of Vilacolics you are using? Okay, Vandana, we are using 200 per day once the follicle is 14 mm. We can unmute Vandana, I think. Deepak
I
sir?
think we can unmute everyone.
Yes, yes. So everyone can have a free
Everyone can
discussion.
unmute
Smita, अपना जी
themselves
question
only.
असे कि patient compliance. I think so far none of my patient is complaining of anything. Anything about the PPOS ki they are having any issues with the progesterone?
No complaints, sir. No, absolutely no complaints.
But the cost is maybe an issue because oral antagonist is, I think, costlier than the this apna medroxyprogesterone.
Yeah, it is little costlier, but then the duration, like, see, we were giving from day two, and we used to continue after pickup also. But oral antagonists are little costly than that, but we are here the duration of treatment is less because we are starting once the follicle is 14 until the day of the trigger.
Concern Preeti is right. Oral progesterone, oral antagonist is very, very expensive comparison to the
Expensive.
progesterone.
In comparison to, yeah, that is,
Yeah. My
right.
only benefit I see, I am not, because I did not find any study after oral progesterone, oral antagonist. Can we go ahead with the fresh transfer?
See, sir, as per literature, we can, but practically, I don't know. I don't
Yeah,
know the effect of the oral antagonist on the endometrial receptivity. But
should not be there. But I
yeah,
didn't find any studies.
any studies I have not got.
Ma'am, I have a question. In the oral, this antagonist protocol, if we are using oral antagonist, what is the dose that you are matlab, using for it?
We are using 200 milligram per day once the follicle is 14
Okay,
The
so we
same way
start.
we are using the injectable antagonist, the same way we are using the oral antagonist, only that is the injectable form. This is the oral form in the dose of 200 milligram per day.
Manoj,
मैम
are you there?
बताओ। यस सर,
हाँ
यस सर, आई एम
मनोज,
मनोज,
किसी का
लिसनिंग।
भी
please give
ओवुलेशन
the
मिला आपको?
हाँ प्लीज गिव योर
नहीं सर,
फीडबैक
एक में भी
मनोज.
नहीं मिला सर।
किसी का भी
एक्सक्यूज
नहीं
मी
मिला ना
मैम।
ओवुलेशन?
Yes.
नहीं सर, एक में भी प्रीमेच्योर एलएसएस नहीं हुआ है, एक में भी ओवुलेशन नहीं हुआ है।
वेरी गुड। और कितने पेशेंट में हमने यूज किया अभी तक?
33 में सर।
33 में। इसके स्टडी को खत्म करो।
जी सर, हाँ जल्दी कर देंगे सर। बस कुछ डाटा
सर
बाकी है।
ये डे ऑफ ट्रिगर
मनोज,
तक दे
नेपाल
रहे
में
हैं?
शांति है ना?
कृतिका
मनोज,
कुछ पूछ रही है।
ओ या हाँ सॉरी.
मैं ये पूछ रही थी मैम कि टिल द डे ऑफ ट्रिगर ही दे रहे हैं
हाँ
इंजेक्टेबल एंटागनिस्ट की तरह?
हाँ सेम टिल द डे
एंड
ऑफ
मैम,
ट्रिगर.
पीपीओएस में अगर हम यंग ग्रुप ऑफ पेशेंट्स की बात करें तो हैज देयर बीन एनी डिफरेंस इन द प्रेगनेंसी आउटकम, मतलब हैड बीन कि कोई
नो
बायोकेमिकल प्रेगनेंसी, अबॉर्शन रेट?
नहीं नॉट एट ऑल. पीपीओस में तो नॉट एट ऑल. आई एम नॉट गेटिंग एनी डिफरेंस. जस्ट ऑफ लेट in few of the conferences I have heard and few articles ki in elderly group of patients the aneuploidy is more with PPOS in elderly group. So in my very elderly group where the patient is 38 37 38, in those group of patient I am either using oral antagonist also or sometimes the injectable antagonist.
Okay.
For the fear of aneuploidy, though I have no proof, like I cannot prove that yes, the aneuploidy is more, but just to be on the safe side, because those are very poor reserve patient already, I am getting only 5-6 follicles, 5-6 eggs like that. So I don't want any rate that the aneuploidy should be more. So in those patients, just to be on the safe side, I am using antagonist protocol.
Okay, ma'am.
Till further proven, actually we need more studies also now. So till it is proven, till that time, I think I'll go ahead with the same.
Ma'am, when you're using this oral antag, no, so you'll be continuing with the same dose of medroxyprogesterone, or you're going to increase the dose? It'll remain the same only?
Or if I'm using oral antagonist,
Yeah.
if I'm
Yes,
using
of
oral
Cetromix.
antagonist, if I'm using oral antagonist, Vandana, I'm not using medroxyprogesterone in that case.
Okay, so you're talking about antag.
How oral antag is same like an antag.
Yeah.
Just that is in injectable form. This is an oral form. You use it in the same way, in the same either the fixed protocol or the flexible protocol. Fixed protocol when you start on the day 6, or the flexible protocol when you start when the follicle is more than 14 The fixed protocol also sometimes I have used. Suppose I have done the scan today, tomorrow I will not be able to do the scan. Maybe I am on a chutti or something, and I don't want any any problem. So sometimes I start on the fixed protocol also. Day 6
Okay.
and I start the antagonist.
Okay.
And dose
Yeah.
is 200 milligram once daily.
Once
This
daily.
is what,
Once daily.
yeah,
Yes,
this is
not
what we
daily,
have
once
used in
daily.
our patients.
Okay.
One more question, not related to the stimulation, but ma'am, this alcoholics, does it have any effect on the adenomyosis and all? Are you using it before the FET preparation?
Oh, I have used in one patient. Actually, I had used it for two of my patient. In one patient, I used it worked just like an injectable instead of the depot because I had already given depot to that patient for 3 cycles. Then I had done the IVF. It tested negative. Again, I wanted to do, and the patient wanted to postpone due to financial or some reasons like that, personal reasons. Then I started her on the oral antagonist for 3 months. And then now again, I have done the IVF for that patient. So I'm waiting for the result. And one more patient I had started for the same reason. Then the patient was having some symptoms. She was saying she's having gastric symptom, too much of acidity and this, that after starting the tablet. So I stopped it. So I have started using the oral antagonist actually for those purposes also.
Ritika, recently one patient was referred to me from the
Yes,
base
sir.
hospital, and she was taking oral antagonist for last 4 months.
Okay, sir.
When we saw her, I did not find anything. There was no adenomyosis, uterine cells are perfectly normal, and I was literally wondering why she's given oral antagonist. I think Deepa or Preeti was with me. I didn't know which one was there with me. And we were literally surprised why antagonist was given. When we looked back into the previous ultrasounds, there was adenomyosis, there were endometriosis in laparoscopy, but patient was totally asymptomatic when patient came to us. So I do think it's, but just one patient I have experience, that too
Uh,
prescribed by someone else.
Sir, my patient too, it worked very well. The second patient also who was having symptoms, she did have her menses for 2 months. She was not having her menses. The cycle was suppressed, the endometrium and everything otherwise was suppressed. And the previous patient, her the uterus volume, everything had decreased. So it was
It
showing
was
very good
wonderful. I
result.
couldn't see any sign of adenomyosis or endometriosis at all when patient came to us. Preeti was there with me or Deepa was there? Who was there with me?
Sir, I was
Recently
there.
we have seen Deepa was there with me.
Yes, sir.
4 months she was taking and absolutely symptom free.
Yes, sir.
No
Sir,
adenomyosis, no symptoms at all.
uh,
So what was the dosage that was
actually,
used?
people are using oral.
See, you can use either 200 milligram per day or 150 milligram
So
per
for
day
your
also you
patient.
can use
Okay.
it. I have given 200 milligram per day.
Even the patient which came to us was also taking 200 milligram OD.
Mm-hmm.
100 milligram. And is it similar for like, ma'am, have you used for endometriosis also with big endometriomas or something?
See, I have not used till now, but I will.
Okay, because many of my gynae friends who are gynecologists who are using it for endometriosis, and they are saying that at the dose of 200 milligram BD, they are having very good response for like for pain at least, and the dysmenorrhea.
See,
So
actually, I had had
I was
two
asking.
CMEs. We had two CMEs on this oral antagonist. So one was for fibroid and one for endometriosis and adenomyosis. So see, like personally, I have not used, but in the CMEs, like we had number of articles which were displayed and all. So they were saying that in fibroids also you can use it. It will decrease the bleeding and pain. Basically, in fibroids, it decreases the bleeding of the patient, the discomfort, the bleeding and pain. And in endometriosis, adenomyosis also it can be used. It decreases the pain. It gives a good pain relief to the patient. Bleeding, pain both will decrease. So there are studies where people have used it for endometriosis, adenomyosis, for fibroids as well. So I think we all can give a try. See, until unless we use it, we will not know, isn't it? Like now I have started using, I have used for some of my patients, I am getting encouraging results. So I feel like using it more. It's like that.
Cost is the only inhibiting factor.
Yes.
Yeah.
Who is
Thank you,
this?
ma'am. Thank you, ma'am. Thank you,
Giomi
sir.
Giomi has disappeared. Anyone knows who was this Giomi? अरे मैं पूछने वाला था वो गायब हो गए. Somebody
So
was there
actually,
with
I
a
have shared the link in few of my groups now. So I don't know,
Mhm.
maybe someone from there.
Possible. Manisha also
Uh,
asked me whether she can share. I told her, but Manisha herself did not come today.
No, she joined. I think so. She joined. Maybe she has left in between.
Okay.
So, sir, I think if does anyone has any more queries, or otherwise, I think we can end this webinar. So, what do you say?
Yes, I'm missing my coffee of webinar seminars.
Yes, sir. But late night now, so we cannot have coffee. Otherwise, we will
Yeah.
not feel asleep at night. So, so Dr. Preeti, thank you so much. It was a wonderful talk, and I think we had a much lively discussion, and everyone of us shared our experiences. So, thank you all of you who were present with us today. I would like to thank all our past fellow students also who took out their time to join us. Thank you, Dr. Deepak sir, and thank you, Dr. Ritika Gupta. So, I think with this we come to an end of this webinar.
Thank,
Thank you, sir,
Thank
and
you.
thank you, madam.
thank you, ma'am. Thank you, sir. Sir, one request. We should be
हाँ बोलो
having
ना.
such webinars more often.
We will have. Next
Yes.
seminar, I think Smita is presenting something.
Okay.
Something interesting Smita is going to present in the next seminar. So let's see.
Yes, sir.
Thank you. Chalo. Good night,
Okay,
everyone.
thank you so much.
Thank
Good
you,
night,
sir.
everyone. It
Thank you,
was a
sir.
pleasure meeting you all. Thank you.
Thank you all.
Same here, ma'am.